Understand the role of endoscopic ultrasound in diagnosing pancreatic cancer. Hello, this evidence-based content is prepared by Saboor fellowship-trained consultant surgeon, and if you or someone you care about has been told they might have pancreatic cancer, you're in the right place. I know when you hear the words pancreatic biopsy, it's natural to feel overwhelmed and perhaps scared about what that means. EUS-guided biopsy combines two technologies, an endoscope, a flexible tube with a camera, and an ultrasound probe. The doctor passes this through your mouth, down through your stomach, or small intestine, getting incredibly close to your pancreas. From there, they use real-time ultrasound imaging to guide a fine needle directly into the suspicious area to collect tissue samples. According to the medical literature, EUS-guided tissue sampling achieves both sensitivity and specificity above 90% for diagnosing pancreatic cancer. Sensitivity means the test correctly identifies cancer when it's present. So if you have pancreatic cancer, there's better than a 90% chance this biopsy will catch it. Compare this to the alternative percutaneous biopsy, where a needle goes through your skin guided by CT or ultrasound. That procedure has sensitivity in the range of 80 to 90%. EUS-guided biopsy works even when the tumor is poorly visualized by other imaging modalities like CT or MRI. There's a theoretical concern that when you stick a needle through the skin and into a pancreatic tumor, the percutaneous approach, you might spread cancer cells along the needle path or into the abdominal cavity. The data reveals that EUS-guided biopsy significantly reduces these risks because the specimen is obtained through the bowel wall rather than percutaneously. Studies show that while the risk of tumor seeding from percutaneous biopsy appears quite low, or even absent concern, persists in clinical practice. In one study of 41 patients undergoing resection for pancreatic cancer, those who had percutaneous biopsies showed no increase in positive peritoneal washings or worse survival. EUS-guided fine needle biopsy can sample solid pancreatic lesions located anywhere the pancreatic head, neck, body, and tail. The pancreas is a notoriously difficult organ to access. It sits deep in your upper abdomen, tucked behind your stomach, and surrounded by major blood vessels. Because the ultrasound probe is positioned right next to the pancreas through the stomach wall, it provides much higher resolution than transabdominal ultrasound. Pancreatic cancer on EUS appears as a hypoechoic mass, a dark area on the screen, typically with dilation of the pancreatic duct upstream. EUS-FNB fine needle biopsy, as opposed to fine needle aspiration, is particularly helpful when additional tissue studies are necessary. I'm talking about molecular testing, analyzing the genetic makeup of your tumor to guide treatment decisions. In the modern era of personalized cancer treatment, knowing the specific genetic mutations in your tumor can determine which chemotherapy regimens might work best. A diagnostic biopsy of a suspected pancreatic malignancy is mandatory in almost all cases, but there's an important exception. Biopsy is essential if you have distant metastases and need tissue confirmation before starting chemotherapy, or if you're not a surgical candidate. If you're a fit patient with a resectable pancreatic lesion that's highly suspected of being malignancy based on imaging and you're headed straight to surgery, a preoperative biopsy will not be needed. The negative predictive value of both percutaneous and EUS-guided biopsies is only 60 to 70%. The data shows that between 5 and 11% of patients who undergo surgery for a presumed pancreatic cancer actually have benign disease, most commonly focal chronic pancreatitis or autoimmune pancreatitis. These are the conditions most commonly mistaken for pancreatic malignancy on imaging. This image shows other features of EUS that are useful, other than biopsy. Write down your questions before your appointment. Specifically ask, do I need an EUS-guided biopsy or am I going straight to surgery? If I'm having a biopsy, will you be collecting enough tissue for molecular testing? What are the risks specific to my situation? How long until we get results, and what happens next? If you've been told you need a biopsy, ask where it will be performed. EUS-guided biopsy is operator-dependent, meaning the skill and experience of the endoscopist matters. Research shows that outcomes vary with locally available expertise. You want this done at a center with significant experience in pancreatic EUS. Arrange your support system now. You'll need someone to drive you home after the procedure because you'll be sedated. But more importantly, you'll want someone with you when you get the results. If you're supporting someone through this, your presence at that appointment matters more than you might realize. Ask about the specific type of biopsy recommended. Is it EUS-guided fine needle aspiration FNA or fine needle biopsy FNB? FNB provides core tissue samples and is particularly useful when molecular testing is planned. Make sure your medical team knows you want molecular testing if cancer is found. This isn't always done automatically. Discuss the staging workup. EUS-guided biopsy is often the best modality for obtaining tissue diagnosis, but it's part of a larger staging evaluation. You should also have multiphasic contrast-enhanced CT of your abdomen and pelvis. Ask what other imaging studies are planned and why. After your EUS-guided biopsy, contact your doctor immediately if you develop severe abdominal pain that's getting worse, fever, over 100.4 degrees Fahrenheit, vomiting that won't stop, or black tarry stools or vomiting blood. These could indicate complications like pancreatitis or bleeding, which occur in a small percentage of cases. The mortality rate for ERCPA-related endoscopic procedure is 0.2%, with complications including pancreatitis, bleeding, and infection. While EUS-guided biopsy is generally safe, you should know what warning signs to watch for. If your biopsy is negative but symptoms persist, insist on follow-up imaging. Remember, a negative biopsy doesn't definitively rule out cancer, especially if imaging and clinical presentation remain suspicious. Some centers will proceed to surgery based on imaging alone in fit patients with resectable lesions, precisely because of this limitation. EUS-guided biopsy achieves over 90% accuracy in diagnosing pancreatic cancer while minimizing tumor seeding risk through a safer anatomical route. Your next step: prepare your questions and ensure molecular testing is planned if cancer is found. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.